Now, we have some questions from Nicola, who at the time when she submitted the questions was up to about module 4, and which is a good question. This she asks, you know, if you're looking at improving the smile to build out the buccal corridors posteriorly, what can you do if the patient has unrestored teeth? Which is a really good question. So the best place to start really with buccal corridors, if you want them to make them look broader, first of all is whiten them. So if you do whitening with one of the whitening protocols, this will make them higher value, and it will give the illusion of making the buccal corridors look wider. The second choice, which is the kind of the best non-restorative approach, is orthodontics. So during the course, and certainly during the level 2 course, we look at cases where we've done orthodontics, and the orthodontics has managed to expand out the buccal corridors. The final way, and we'll be doing all the veneer preps on the hands-on course, is essentially with posterior veneers if the teeth are unrestored, or if they're heavily restored or root filled, with crowns. But bear in mind, we're now getting into the realms of more aggressive and invasive dentistry. And also, if we're going to be doing posterior veneers, there's a lot of occlusal criteria to look at. You would not want to be doing posterior veneers on buccal corridors if there's parafunction, or if the patient doesn't have protective canine guidance. The other way potentially to build out the buccal corridors posteriorly, again, is if you don't want to go to formal veneers, you could do BioClear composites. But whichever technique you go for, make sure that you are making sure that these veneers, when the patient goes from side to side in lateral excursion, are out of the occlusion. And also accept with posterior veneers that there's no studies on them. All veneer studies are done on anterior veneers, and success rates are 90% at 10 years, 75% at 15 years. But these patients have good occlusions, so no parafunction and protected occlusions. My failure rate with posterior veneers is higher than my anterior veneers. My anterior veneer failure rate is virtually 0 because I'm very selective. And I know some of the questions later will come back to veneers, but do expect, when you're getting informed consent, let your patient know that failure rate with posterior veneers likely to be more like 10%. It's likely to be higher because the occlusal forces, you're right under the masseter muscles here, the occlusal forces are much stronger.